Hey everyone, I see that we have therapists from all over the country in the chat. Thank you so much for being here. Yeah, drop your names and where you're from. I'm really interested to see how far we're reaching. Oh, South Africa. Hi, South Africa. So if you're not sure where you are, this is a webinar for Outro, specifically for therapists to talk about deprescribing or tapering antidepressants when you're working with clients. And medication's kind of weird because it impacts our work so much, but we're kind of get the sense we're not really supposed to talk about it. It's outside of our scope, yet it comes up all the time. You'll have clients who come in and they say that they went off their antidepressants and they think they're relapsing, but they don't want to go back on. So they're trying therapy, or you have it on your intake forms. And so you know exactly what medications they're on and you are aware of their history, but again, it's kind of off limits. So I'm here with Mark Horowitz, a real life psychiatrist who says we can and should talk about these things. And he's going to tell us the ways that we can best support our clients through those conversations. So,
Yeah. Thanks, Megan. Yes, so that's right. So uh, I'm a trainee psychiatrist and a researcher. I work in the UK, but I've helped to set up Outro. I've done a lot of work on how to safely stop psychiatric drugs, especially antidepressants. I helped to write some of the national guidelines that we have in England. A lot of my work has come out of my experience in having a lot of trouble coming off antidepressants, especially Lexapro, but also Remeron. So I've sat on both sides of the desk. If I hadn't have gone through the process of coming off the drugs myself, I never would have understood what I now understand because of what I'd been taught in medical school and my psychiatry training. So it was both a scary and a very eye-opening experience to go through it. And that's what sort of led me to research this area and to try to make sense of it more fully. Um,
and some of you might know me. If not, my name is Megan Cornish. I am a licensed clinical social worker. I work with several mental health tech companies, mostly around writing and strategy. Mostly I am here because I begged Outro to let me be a part of what they're working on, because I have tried to get off antidepressants myself. I've been on Lexapro for 15 years. I've tried to go off 3 times. Figured I'm just a lifer. I don't have any problem being on it, other than it's inconvenient and it's expensive and it would be nice to get off, but I can't. And then I found out about Outro and I'm now uh, on my fourth and most successful attempt, slow attempt to get off Lexapro. So I'm very excited to be a part of this and to pick Mark's brain a little bit more today.
Great. Um, so, so I'll talk in general about what role do therapists play in the journey of antidepressants? What role can you play? Um, so, go through a few things.
And if you have questions, you can drop them in the chat. I'll keep an eye for them, or we'll make sure and get to them at the end if we don't have time while he's speaking. So
I think we're gonna talk about why would people want to stop an antidepressant, what is antidepressant withdrawal, and why is it mistaken for a return of someone's underlying condition or relapse? What is this strange jargonized term, hyperbolic tapering, and why are people using it to stop antidepressants like SSRIs? And how can therapists play a role in this? How can they support clients thoughtfully, ethically, and within scope? And how might we work with you um, in order to provide patients with a safe pathway to stopping their medications? I might just skip to the second last point for a second, and we'll come back to it. So I worked with a therapist in the UK who got together all the major therapy organizations to put out a booklet um, that it tried to explain to psychologists, to licensed social workers, to analysts, whatever sort of therapists people were, about how to talk about psychiatric drugs to their clients. And she did that, and all the major therapy organizations got together in order to encourage therapists to have those conversations under the rationale that therapists often know their patients, clients better than doctors do because they see them more often. They have a lot of insight into the ups and downs and how medications play a role. it may not be the role for a therapist to say, you should take this medication or you shouldn't take this medication, giving direct medical advice, but giving medical information, this drug can cause withdrawal effects. Here is a legitimate website to look at for more information. You might want to talk to your doctor about that issue, is perfectly within scope. Any website that has information about medications is providing medical information. So you should certainly be able to do what any website can do. And the whole idea was to get therapists, psychologists to lean into these discussions rather than being pushed out. Because I do think, we're just having a quick conversation before we spoke, there is a little bit of a muscling out by doctors who say, we're very clever, we know all these things, you guys talk about childhood, that's all great stuff, wonderful stuff, but, we're the serious people with the medications. I think it is reasonable to say that doctors are writing prescriptions and making medication decisions, but it's everyone's business, the health of a person. So I think there is a role for therapists to add information, um, and, uh, uh, and as you'll see, I think the other point is doctors are not as well informed about these issues as you would hope they would be. So that's another thing that will come up.
Yeah. I think that I've posted a few times about outro on my LinkedIn, and I've gotten some interesting conversations where there's still so much fear about stigma around antidepressants that now there's like a anti-stigma type thing where if I post about going off of my antidepressant, there's a fear that that might be seen as being antidepressant and shaming the people who are still on them. But I think we can safely, within our role, both as psychiatrists and therapists, say that we want our clients to have what they need to thrive and not to have anything in their life that's not necessarily contributing to their thriving. So we want them to have it if it helps them and not have to deal with it if it's no longer serving them. So being able to delineate between those two with the help of a prescriber is really the best pathway for everyone.
Yeah. So it's a very interesting point you bring up, Megan, about what happens online. I think it's slightly hysterical, talking about the benefits of drugs and the side effects of drugs and how to stop them, is exactly what medical scientists, what doctors, do all the time. And somehow when you talk about any negative sides of medication or how to stop it, you're suddenly an anti-psychiatrist or anti-medication. To me, it's a bit of a hysterical jump. People who talk about what's the best way to stop a statin cholesterol medication or what are the side effects are not accused of being anti-cardiologists. So there's a slightly hysterical flavor to things. People might find medication helpful, but at some point, most people should stop it according to the guidelines themselves. So it's hardly outside of the beltway to discuss those issues.
Absolutely. I love that analogy because it's progress is when we get to the point where it's talked about just the same as any other medication.
Exactly. In fact, it might even be stigmatizing not to talk about these things. To assume that everyone must be on them, for their entire lives is itself,
Yes.
not really applying critical faculties to the issue. So let's talk about why people might want to stop their antidepressants and what the context is in general. On the right-hand side, you can see prescribing rates in America for antidepressants. And this is actually already several years out of date. But the key line is, the red line is people who are on antidepressants for more than 5 years, is skyrocketing. It has gone up, a dozenfold in the last 10 years or even less. Um, that is because people are staying on these drugs longer, and people think in part it is because they're finding it hard to stop the drugs, and also because people are being told they need to take these drugs, long term to correct a chemical imbalance, which we talk about is not an evidence based position. There's a lot of people on multiple drugs these days. A lot of people are prescribed an antidepressant in the context of a stressor, you know, divorce, job loss, death of a loved one, moving cities, illness, something that gets them into a state. And many people will move through that and will no longer need the medication. The American Psychiatric Association guidelines recommends that most people with anxiety and depression are given the drugs for 6 to 12 months. So this group of people who are on drugs for 5 years or more, it is now, more than 20 million adults in America, is really mostly using these drugs beyond even what doctors recommend. A lot of people want to try other ways of coping. And there are many adverse effects. There is sexual problems and lack of desire, trouble with ejaculation, trouble with sensation. There's emotional numbing, blunting. People feel their emotions less on the drugs very often. Some people are not aware of it until they come off the drugs and see things in hindsight. Weight gain, cognitive impairments, trouble with memory, trouble with concentration, daytime fatigue, trouble sleeping at nighttime, increased anxiety for some people. In the long term, some people have worsening mood because of the drug, something called tardive dysphoria. There are a lot of different reasons why people might want to come off the medications. There's a whole series of physical health problems that can happen to people who are over the age of 65. So lots of reasons to come off, especially as you get older.
You sound like the end of a medication commercial there.
Yeah, they say it very quickly though.
Yes.
And
Fast forward.
yeah, in sort of medical school, I was taught, these leaflets you get with the drugs that have a long list of possible side effects. Don't worry about them; they're written by the lawyers. Blah, blah, blah. I now realize what I often do in my clinic that I run in London is I get people to circle the symptoms that they have from the drugs, the side effects listed on these leaflets, and people often circle 15 to 20 different side effects on the drugs, and they never really put together it was the drugs causing it. Because,
Hmm.
of course, if you're on a drug for 2 years, 5 years, 10 years, it's almost hard to remember what you were like before you started the drugs. It's not like an antibiotic where you take it and you feel nauseous the next day. It's obvious it's the antibiotic. Antidepressants are much more subtle. If you develop gut problems or emotional numbing or so forth, you don't quite, you don't often put your finger on it. And so I've decided these lists of symptoms are really important. The lawyers wrote them. In other words, they wouldn't have written them if they weren't, really happening and they were getting into lawsuits about them. So
Yeah.
I've flipped my orientation to those symptoms. So then that's the issue with, people being on the medications, why they want to stop and what makes it hard to stop. So, I think a lot of people have this sense if someone is finding a drug hard to stop, it means they probably need it. It sounds, Megan, like you came to that conclusion in the past. You came off, you
3
probably felt,
times. Yes.
you felt awful. You thought, well, this means that I need it. And you can see why that would be. I think a lot of people have been told, they've got a chemical imbalance in their brain. That's why they need the drug. That's the sort of uh, colloquial way of saying low serotonin, and the drug is going to replace it. And if you stop it, it's like stopping insulin if you've got diabetes, and then the diabetes comes back. But the story, as it turns out, is slightly different. There is no proven chemical imbalance in depression. That was really a marketing line. That was incredibly successful in America. There's been now 6 decades of research into serotonin and depression, and the verdict is pretty clear. There's no difference between healthy volunteers and depressed people. It's not a simple chemical reduction. It's a very complex collection of what's happening in our lives and our childhoods. And so antidepressants are nothing like insulin for diabetes. And when you come off them and feel terrible, it sort of fits that narrative. And there's a second reason why you might feel terrible coming off an antidepressant, and that's withdrawal effects. Um, you know, the about half of patients experience withdrawal effects when they stop. The longer you use them, the more likely they are. There's a quote here. This is a 1990s drug company memo where they clearly knew about these issues as soon as the drugs were on the market, but they didn't want to tell the regulators because they knew it would impact the sales of their drugs. So they concealed them. They did lots of very tricky things, but now it's coming out much more in the open that there are withdrawal effects. Um, some people kind of think that means the drugs are addictive. There's a sort of semantic issue here. Antidepressants don't get you high as a kite like, heroin does or opioids. So they're not addictive in the technical sense. There's another term called physical dependence, which is what happens when you use a drug several times it affects the brain. So, for example, caffeine causes physical dependence. So I guess that everyone in the audience is physically dependent on caffeine. If you stop caffeine, you'll get a headache and feel terrible. But also, I guess no one is stealing from their neighbors or injecting caffeine because there's no addiction issues. And the same is true for antidepressants, although the withdrawals from antidepressants is way more vicious than coming off caffeine. Let's keep going here. This has sort of come out into the public domain, both through research and through reporting. So this was kind of a landmark paper story in the New York Times, 2018, where they described how much trouble people have when they try to stop taking antidepressants. They were deluged with patient stories. They ran 2 articles about it, um, and the reason why this has all sort of come out as a problem is, most doctors are not trained in how to stop the drugs. I think people find that both baffling and a bit scary. That I can report that when I went through medical school and psychiatry training, I was given hundreds and hundreds of lectures on how to start drugs, and basically no lectures on how to stop them. And that's because all the studies are done by drug companies. They're all about starting them. There's very little incentive for them to do studies on stopping them. Guidelines are based on existing studies. And so there's often pages and pages and pages on which drugs to start, and then a little kind of sentence, and you can just stop the drugs over a few weeks, we think, is basically what most guidelines say. And so most doctors are not very well trained in how to stop them. In different studies, there are success rates as low as 6%. That is, if you give a patient who wants to come off their drugs, that they'll be successful in 6% of cases. Other studies show it's as high as 30%. A major issue is doctors make the exact same error that Megan made of mistaking withdrawal for a relapse. And again, it's very, and I should say, most treatment for antidepressants is given by primary care physicians, family doctors, not by psychiatrists.
Well, I'll throw out there that I am working with a psychiatrist. I have a psychiatrist who I really appreciate, who has listened to me a lot and who has tried to help me get off 3 times. And in fact, I send him your guidelines. I'm sure he really appreciated that, me sending him, and just said, I'm going to try this. So hopefully him getting those will maybe help the next person. So
maybe it'll get into his mind. And I guess, one manifestation of this sort of mismatch between how much trouble people have coming off these drugs and how little doctors understand about this is a huge efflux of patients from doctors' surgeries onto online forums. So there's a website called Surviving Antidepressants. There are Facebook sites with names like Cymbalta Hurts Worse. You might recognize those as popular antidepressants. And they are full. I think the latest count is 250,000 people, half of them from America, and they all have the same story. It's all basically Megan's story. I tried to come off an antidepressant. I felt terrible. For whatever reason, I felt different to how I felt originally. I had brain zaps, the sort of electric shocks in my head. I felt dizzy. I had a headache. I've never had panic attacks before. I had panic attacks. I went to my doctor. They said, this means you need the drug. And I said, but, aren't there withdrawal effects? And they said, no, these drugs don't cause withdrawal effects. This is not heroin. And they end up my doctor has no idea what he's talking about. And they end up on a peer support forum to get advice. And I guess the reason why I'm here is even though I have 6 academic degrees and a PhD in how antidepressants work, I got advice on how to come off my antidepressant from Surviving Antidepressants. So, I was taught how to come off my antidepressant by a retired software engineer, even though I was, sort of amongst the cream of the crop
wow,
researching these drugs.
wow, that's incredible.
Yeah. And I guess that's why we set up Outro, to try to prevent that happening to other people, what I went through.
It's about
Um,
time.
and so this was a survey we did of people on these sort of websites. Why do they want to come off? You'll see some sort of overlap with what I mentioned before. They want to see, can they live without the drugs? They're concerned about becoming dependent on them and getting withdrawal effects when they come off. They're concerned about the long-term effects. So some people might be older. I'll just give you a quick rundown that for people over the age of 65 in particular, being on an antidepressant probably increases your risk of stroke, falls, fractures, osteoporosis, cataracts, and probably even an early death. So there are lots of reasons why it's wise to come off these drugs as you get older. Some people feel better and therefore don't feel that they need the drugs anymore. I've mentioned a whole list of side effects that people might want to avoid. People feel the drugs are not effective, which is true for many, many people. And there's a group of young women who want to become pregnant and know that being on these drugs will probably increase the risk of having fetal abnormalities in their offspring and want to avoid it. So we've sort of said there's concern over long-term effects, don't rely on a medication, unpleasant side effects. Oh, this is from Outro, so this is from the people we've seen already.
Specific to who you are with, yeah.
Outro, yeah. So we see very, very similar things to the broader group. Unpleasant side effects, desire to try non-drug options. Of course, there's more and more evidence that other options can be either as effective or even more effective in the long term. And there are many people who are not helped by the drugs. I'll just speak to that for a second. Even in the most industry-friendly trials, run by the drug companies, reported by the drug companies, it takes 7 people to be given an antidepressant for 1 to have a benefit over placebo. So it's number needed to treat of 7. So 6 out of 7 people we know do not receive any more benefit from antidepressant than they would have got from a sugar tablet. So it's, these drugs are, even by the biggest supporters, recognized to be fairly minimal in their effectiveness. To return to withdrawal, there's a few more things to say about it. So number 1, what this graph is showing on the right-hand side is very simply the longer you use an antidepressant, that's the x-axis, the more likely you are to have trouble coming off it. So if you're only on the drug for a few months, withdrawal effects are generally rarer and they're generally mild. And that's where the drug companies did their studies, by the way. That's why a lot of the guidelines say withdrawal effects are brief and mild, because they were after 8 weeks of use. But once you're with most Americans and using the drugs for more than 3 years, most people have withdrawal effects. And for half of them, they're moderately severe or severe. And that's because the longer you use the drug, the more your brain gets used to it, the harder it is to stop. That's why your brain screams out for the drug. That's withdrawal effects. I also think there's sort of a general recognition. Yes, people get headache, they get dizziness. It's a bit unpleasant for a week or two. That's the kind of popular notion of withdrawal. That is not what happens to many people in real life. Withdrawal can last for months and even years. It can be debilitating. People end up bedbound. People lose their jobs. People lose relationships. I've had a very large number of people say the withdrawal effects were way more severe than the issue I was put on the drug for. No, some of them say no. Some of them say I'd have it 10 times again. The divorce, my mother's death, even compared to what I went through coming off these drugs. There was no comparison.
Wow.
And the reason why we think these symptoms can last so long is that's how long it takes your brain to recover from these drugs. It doesn't just sort of snap back in a week or two. It can take months or years for the effects of the drugs to kind of be come out of your system. This is basically saying that with the cartoon, basically that it can take months and years for the brain to get used to the drug not being there, and that's why withdrawal effects can last so long. I won't go into too much detail. This is a really important point, both for doctors and for therapists. There is a very long list of withdrawal effects from antidepressants. There are cognitive effects. People can have concentration problems, memory problems. There are many psychological symptoms. You can get anxiety, low mood, panic attacks, become very obsessional, become suicidal. Almost any mental health symptom out there you can get in withdrawal from the drugs. And it's obviously because it's affecting the chemistry of the brain, and that's leading people to have these sort of symptoms, like a hangover from alcohol or something like that. It obviously causes a lot of mood symptoms. And there are lots of physical symptoms, trouble with balance, dizziness, headache, brain zaps, ones that are a little bit more well known. Withdrawal symptoms could come on either a day or two after stopping, or sometimes a few weeks later. And that's another thing that very much confuses doctors. In the textbooks, it says withdrawal effects, must come on within a few days. But But I see, and there are studies now that show it, that they can be delayed by many weeks, and that kind of adds more confusion to people trying to work out what's going on here. And I'll just say it's the psychological symptoms, if you go to the top right here, the most overlapping symptoms that cause the most confusion. You walk into a doctor's office and you say, I've just stopped my drugs, I feel horribly anxious, I feel suicidal. You're not going to get any further in your sentence before they say you must need to go back on the drugs, you've relapsed. Very few doctors sort of know to go down the list and ask, by the way, did you have brain zaps, these little electric shocks? Did you have this feeling of agitation and restlessness? It's called akathisia. It's a Greek word for can't keep still. One of the worst symptoms of coming off. People can, completely lose the plot when they have these symptoms. They are pacing, full of terror, really disturbed. Are you dizzy? Are you lightheaded? Do you have balance problems? Do you have vertigo, nausea, sensitive to light and noise? There's this whole list of symptoms that can help people distinguish, is this withdrawal or is this your original condition coming back?
Mark, do
Sorry,
you
you
find
jump in.
that when someone has one of the upper withdrawal symptoms, they will also usually have one of the lower ones?
So some people will only have one withdrawal symptom, and some people will have 15 withdrawal symptoms. So, the easiest case to spot is when someone comes in and says, um, I'm having brain zaps and dizziness. That's not anxiety, it's not depression, that's obvious. But actually, psychological symptoms are the most common withdrawal symptoms. So anxiety, low mood, panic, obsessional thinking, suicidality are the most common symptoms. A good way to unpick it is, what symptoms did you have before you went on the drug and what do you have now? And so I will see, for example, someone will say, my mother died 5 years ago. I was very low. I was very lethargic. I was sleeping all the time. I just felt miserable. I feel a lot better now. And I came off the drug, last year, and I developed panic attacks, trouble sleeping, anxiety. And they're telling you completely different symptoms. But often doctors are kind of hearing mental health symptoms. They're thinking, person's gone bananas again. But they're very different. So it's much more likely they've developed withdrawal effects, rather than they've developed a new onset panic disorder, just that day that happens.
Conveniently.
Yeah, conveniently the day you stop your drugs. But doctors, you'll be surprised. It sounds like a joke, but it happens. That's the diagnosis made all the time. Or patients will say, this is a lot worse than what I had. So it's similar symptoms, but at a much greater intensity. And the last thing to say is, people get depressed because of what's going on in their lives, mother dying, losing their job. If you get depressed, you know, what is there to relapse? I also think there's a little bit of a construction of this term relapse. We become miserable when life is awful. You can't really have a relapse of divorce. I mean, you can marry the same person again and make the same mistake again, but basically, you can't really have a relapse of divorce or job loss or your mum dying. And so this whole construction of, depression and anxiety being this thing that you have in your brain and it comes up, you take the drug away, it's not a very true to life description of what's going on. I can show you data about it, but it just, it's a little bit of a construction as a chronic illness rather than a response to our lives. And that has been finessed, by the drug companies and by biological psychiatrists for many years. So I've talked about the problem. Let me talk a little bit about the solution. A lot of what we do at Outro, sorry, this is going to be a little bit, a bit of neurobiology. I'm sorry to the therapist crowd here. I apologize profusely for what I'm about to do to you. This is basically a sort of a new approach on how to stop antidepressants safely based on biology. And I'll talk you through it with the least possible pain, I hope. What I'm showing you here is um, neuroimaging of the effect of an antidepressant on the brain. I've chosen Celexa, a very common antidepressant in America. That's the x-axis. The most common doses prescribed in America are 20 milligrams and 40 milligrams. And the y-axis has got a very complicated name, but basically its effect on the brain. It happens to be about serotonin. The main point of this graph is it's not a straight line. So going from 20 milligrams of the dose to 40 milligrams doesn't increase the effect on the brain very much, a little tiny bit. Now, the smallest tablet in America is 20 milligrams. Maybe you can get 10 somewhere. But even a tiny little dose like 2 milligrams, which a lot of doctors would laugh at as being homeopathic, actually has about half the effects of 60 milligrams, much bigger than you would think. And the reason for this relationship, and this is called a hyperbola, if you remember a bit of high school maths, is the technical term is law of mass action. But the main thing is when there's not much drug in the brain, every milligram of drug has a lot of effect because all the receptors for that drug are open for business. A bit like the game of musical chairs early on in the game. It's very easy to find a chair, and so everyone wins. As there's more and more drug in the brain, more and more of the receptors are closed for business. And so every extra milligram of drug has less and less effect, like the end of the game of musical chairs. So you get this sort of law of diminishing returns. The dotted lines that I've stuck on here show you what happens when doctors stop the drugs. So the most common way doctors stop the drugs is they go from 20 milligrams to 15 to 10 to 5 to 0, kind of by snapping tablets in half or quarters. It sounds totally sensible. Even numbers, it's easy to explain in a minute, totally great, except it ruins patients' brains. And the reason why it does that, excuse me, Megan, it's my brain too.
Yeah,
Oh,
we're in the
sorry,
same boat. Yes.
yeah, sorry, terrible. If you go from 20 to 15 milligrams, the effect on the brain is not very big. And some people find that okay. Some people find that a bit unpleasant. 15 to 10 causes an even bigger change in effect on the brain. Oh, I think you can't see my cursor, but I'm trying to point to the change on the y-axis. Going from 10 to 5 milligrams causes an even bigger change in effect on the brain. And the final reduction from 5 to 0 is like jumping off a cliff. So it actually has about 20 times the effect of going from 20 to 15 milligrams. And that's exactly what patients say. The first few milligrams were relatively okay to come off, and the last few milligrams were like hell. And when doctors don't see this relationship, and then most of them are not aware of it, as I've come to a lecture of mine, they don't see it. They think the person's fallen to pieces. They've relapsed. They're sick. They need the drug. It was a terrible idea to ever try to come off it, and they put them back on the drug and tell them, and never try to come off because this is what will happen to you. But there's a much more sensible way to come off the drugs. And so in this case, still talking about Celexa, rather than go down by an even amount of dose on the x-axis, you can go down by an even amount of effect on the brain. So I've drawn 4 horizontal lines on the y-axis that corresponds to smaller and smaller sized reductions of dose down to very tiny final doses, in this case, 0.8 milligrams. So that final step down to 0 doesn't cause a bigger change in effect on the brain than the previous reductions. If you kind of imagine walking down, let's imagine this line as a path. Imagine walking down this. It starts off like a country walk, turns into a steeper hill. You got to go slower and slower as it gets steeper and steeper down the final cliff. And because this graph is called a hyperbola, and these doses are arranged along it, this is called hyperbolic tapering. And that's the main approach that we use in Outro and that I use in my clinic, and that there's studies going on around the world that I'll talk about, I think, briefly. To summarize, basically, this is sort of jumping off the cliff. There's a lot of withdrawal in the top graph, a lot of this area under the curve. If you go down in little tiny steps, the kind of gray region is the kind of withdrawal effects. It's much lessened by making little tiny steps rather than big jumps. That's the kind of essence of it. And this is just a study that was done in Holland. Basically, this was a group of people, a little bit like Megan, who were trying to stop their drugs according to their doctors and couldn't do it. They were then given basically a hyperbolic taper. They were given specialized compounded medication that would allow them to come down in exactly the pattern that I showed you. And the effect was most of them were now able to come off their drugs. And these questions were, I think it's a bit too small to see what this is saying, but with the regular doctor's approach, most people said it went very badly. And with the hyperbolic tapering, most people said it went very well. Did you experience withdrawal effects? How severe were they? With the regular doctor's approach, it was extremely severe. And with the hyperbolic taper, it was mostly 2 out of 7. So mild symptoms, a lot less awful.
That's night and day.
That's, yeah. And that's exactly what I see in my clinic every day, is what we're already seeing in Outro. So we think that a lot of people basically who thought they were trapped on their drugs because of how bad they felt coming off it, if they go slower, if they go in this special pattern, can avoid this sort of horrible effects and are able to get off their drugs.
Wow. So obviously my next question is, what do therapists need to know about when they're working with clients to kind
Yeah.
of have these conversations?
So, I mean, I guess
we don't have to pull up the graphs, I know, but
yeah. Well, right. Actually, I pull graphs out a lot with people. I mean, I do it on the street, but I'm not a normal person. But I sometimes a graph you might pull it because people might come in and say literally, I stopped my drugs and my doctor told me it was that's one other thing, maybe I'll say that. Doctors always say it's a very small dose, 20 milligrams. Not because they're crooks or anything, just because it's the smallest tablet, and they're a bit mistaken. They think that the smallest tablet means it's a very small effect. They don't realize that actually the body doesn't care what size tablet you're swallowing. It cares about the effect on target receptors. So, a patient might come in and say, client, say, I just stopped my antidepressant. I feel terrible. Doctor said there shouldn't be a problem. It's a very small dose. You might say, I've heard something different. I've heard actually even small doses, tablets can have big effects. And we can point you to some websites. Outro has a very good educational library. There are other resources around. There's a textbook I wrote. There's free things from the UK. That might be a place to start patients thinking about things. The sort of people who are going to benefit the most from extra care are people that have had withdrawal in the past, people who said, I've tried several times to come off my drugs and I couldn't. People who have been on the drugs for more than a year, people that have been on the drugs for a few weeks, almost never have any trouble. People who are on the drugs for more than 10 years almost always have trouble, and things seem to start to shift after about 6 or 12 months to being more difficult to stop. There are some drugs that are really vicious to stop. I should say every single antidepressant can be very hard to stop. That includes Prozac, which has a bit of a light reputation, but it can be very hard to stop. Lexapro, Zoloft, they all can be hard, but sort of above and beyond them, Cymbalta, Effexor, Pristique, and Paxil are the 4 hardest to come off.
huh.
Paxil's a real nasty drug to come off. But I should say, almost anybody on any drug might have trouble coming off, but these are the people that are going to be higher risk. These are the sort of things you might hear in a therapy session. I feel ready to live off medication, but I'm not sure how to do it. My medical clinician doesn't support my decision because of what's happened last time. That's very common. Doctor says, they might say, Megan, look, you've tried 3 times. I'm sure you'd like to be off the drugs, but that's just the way the cookie crumbles. A 4th time would be silly to try. Just get used to being on the drug. A lot of people will say, I'm on a website, I'm on a social media site getting advice. I feel a bit nervous. My depression is so much worse. What can I do? Should I go back to the medication? They've tried to come off. They feel terrible, and they're thinking this is a sign I need to be on medication, or the kind of the constant. I've tried to stop before. It was awful. What's going on? You might have an answer to some of these questions, or at least signpost people in the right direction. I mentioned this was the guidance in England, written to encourage, so enabling conversations with clients taking or withdrawing from prescribed psychiatric drugs. I hope we can send round a link to that. There's a sort of 50-page version and a 5-page version to get a few overview, and it's written, from therapist to therapist. So that's probably pitched exactly as people want to hear it.
Beautiful.
We are at Outro, we're interested in, working out what therapists are around that know about withdrawal, because, one of the issues is we have people coming off medications. We cover all the medical issues. We are offering some holistic support, but people often want extra support. And, a lot of therapists who are sort of being taught chemical imbalances, drugs, you should encourage people to stay on the drugs, are not well equipped to be able to guide people through these issues. And so finding withdrawal aware therapists, is like gold dust for us. So if there are people that know about these issues, that's very useful for us to refer to. We're always looking for people to who could offer our patients extra support in their process. And so we're sort of, you can see here, we want, we've got the clinicians really, and we're looking for therapists that would
Awesome.
fit
And
that.
to clarify, you guys are not hiring therapists. You're just looking to build a referral network, because there's going to be therapists who have clients who need prescribers who are informed in this, and you guys are prescribers, but you definitely don't want to take anyone's clients from them in a therapeutic role. You just want to offer them support if they don't have a prescriber who can help them with this.
Exactly. So you're right. So we're not hiring therapists now, maybe down the track, but exactly at the moment we're looking for people that we can refer. We're doing the medical things. They want someone who can give them more support. Exactly as you just said. So so these are the sort of things that a therapist could do to inform themselves or to stay up on this field, is to stay educated on withdrawal, to prevent misidentification of relapse, a major driver of long-term unnecessary use, helping clients to be aware of possible withdrawal symptoms, and recommending, there's a few psychotherapeutic strategies for coping. It might be distraction. It might be other things that keep people's stress level down. It might be going back on the drug. It might be going up a bit. There's a bit of it does get into medical territory, often good to have a doctor involved, but even spotting it is a very big deal. To know that this is withdrawal, once you can define the problem, it makes things much easier to work out how to deal with it. And having clients be supported and validated in what they are going through. If a patient's being told by their doctor, this is in your head, you need the drug, to have a therapist that knows more about these things can be life-saving. I can't emphasize that more.
Mark, does Outro help facilitate communication between therapists and prescribers with the client's release of information?
You'll have to talk to the nurse practitioners on the ground. We definitely communicate with people's, primary care physicians. I'm sure that they can be arranged, to send out letters
Gotcha.
when there's.
It was kind of a leading question. I actually asked this question via email to Brandon and Emma, and they said, yes, there is a feature where they are helping facilitate those conversations, obviously with the client's permission, just so that the therapists who are working with the clients can share information and receive information around the client's care. So.
Yes. Also, if you mean our clinicians, of course. Sorry, I thought you
Yeah,
meant.
no, I meant your clinicians.
Sorry. I'm always thinking. Sorry, with us, yes, absolutely. That would be fantastic. I mean, we're doing. Sorry, a lot of what we're doing is trying to work out. Is the rate we're going down at? Is it working for people? Any feedback we get, makes the process, more bespoke. So that would be great to have
Awesome.
that kind of information.
Yes.
We rely on patients to report their own symptoms, but to have extra eyes on it would be, very useful. I guess the other thing is slightly broadening out the discussion. It's tapering isn't just about removing a medication. It's about, preparing people for, a more sustainable way of managing their mental health without these adverse effects, without the long-term consequences. It involves, we sort of offer these things in basic form in Outro: sustainable lifestyle, support systems, mindfulness, and also I think, this is a real issue, I think, for therapists to get into. These drugs are very emotionally blunting. That's probably what they do to people. That's probably why they work. When people feel better. As emotions come back, it leaves a lot of things that were unprocessed. If you've managed your mother's death, divorce by, sort of suppressing your emotions, sometimes these things come back. It's a very good opportunity to actually deal with them in a kind of deeper way. So I think therapists could play a very big role in that side of things. Sorry. And just briefly, I think this is my last thing to say, is, what we do at Outro, so you have a sense of what we're talking about, is, we are assessing people to make sure they're appropriate for an online clinic to come off their antidepressant. We're looking through different risk factors. They will then be given a nurse practitioner who they'll see regularly between every week and every 4 weeks. They run into trouble in between those appointments, they can message. They can get more urgent appointments. We sort of know that keeping a careful eye on these things is the secret sauce. We don't let things get out of hand too much. That way, it's very easy to help people get back on track. We do a lot of compounding medications to make up these smaller doses that I mentioned to make it easier to come off. And we offer this sort of lifestyle medicine support, broad ways to help people manage their symptoms coming off. This gives a sort of overview of a patient journey. As I've sort of talked through already briefly, we are in, I think now, 7 states. I think keep going up. My geography is not very good, so Megan could tell you what states these are if she knows them.
That's New York, Florida, Texas, California, Oregon, and that's a new one. Is that Colorado? The big boxy one? I'm sorry.
I can't.
I'm letting my country down.
Okay. My
I think it is
Australian geography.
Colorado.
Someone will clarify in the
Yes,
messages or
hopefully. Save me from my embarrassment, yes.
and that's our leadership team. Brian Shapiro is an associate professor of psychiatry at University of California, Irvine, and Charlotte Herring is our lead nurse practitioner. Very, very dedicated team, and I think there's a QR code to join our therapist directory. And I'm very happy to answer any questions that have popped up.
So one of the questions is, would love to discuss the differences of scope of the therapist helping with this issue, as opposed to all the withdrawal coaches that have been coming up in the past few years. I have never even heard of withdrawal coaches. Have you heard of withdrawal coaches, Mark?
I have. So there's, I guess because of all these things that have been pushed out of medicine, because doctors sort of don't know these things, a cottage industry of people that understand the issue. Sometimes they are therapists, sometimes they're just experiences they've been through it. And I guess, coaching means that they're, not, it's not a protected designation. So they're just kind of people offering their services. That has sprung up. I think that there is a role for qualified psychologists to both, who can I sort of think about it as both sides of the same coin. There's the withdrawal effects, there's physiological things that are not, not about people's childhood. But of course, there are things about people's childhood and about their relationships and about their sense of self. There is a bit of intermingling between those two things. A therapist that understands both, to me is a, double threat and offers a lot. So I think there is definitely a role for trained professionals to play a role here.
Absolutely. Here's another question for you. Are there any statistics on what percentage of people will experience the more severe or significant difficulties, and are there any risk factors that they can look for?
Great question. I'll just give a quick answer. The number one risk factor is how long you've been on the drug. So this bottom line on this graph is moderate or severe withdrawal effects. If you've been on it for 2 months, the risk is about 1 in 5. If you've been on it for 3 years, the risk is about 1 in 2 of having moderate or severe withdrawal effects. Other issues are which drug it is. Effexor, Cymbalta, Pristique, Paxil, much higher risk. Those are the main issues that we know.
Gotcha. Okay, here's another question that I think compounded medications. That's a good question.
So basically, great question. So a compounding pharmacy is a specialist pharmacy that can make up non-standard doses. So for example, Celexa comes as 20 milligram tablets, sometimes 10 milligrams. A compounding pharmacy buys the drug as a powder, and it can make up 1 milligram or 13 milligrams or 3.65 milligrams. It can make up any dose that you want, and it allows you to make this hyperbolic taper with these sort of specialized doses.
Yeah. For example, I am on my pills are 10. I'm down on 7.5, but I'm going to need to get down to very, very small doses. And my husband happens to be a nurse practitioner. My next door neighbor is a pharmacist. So between the two of them, they're going to handle their own little compounding pharmacy. But without that, and Oucher's not available in my state, so I don't know how I would handle it. There's a question here about the lack of evidence of chemical imbalance. We'd probably, I could talk about this topic all day long. They're saying that they had a dramatic change, that antidepressants helped them a lot, and it did for me as well. So they're just wondering what you attribute the the
So I'll
impact.
talk about that. I'll talk about that for a couple of minutes. So this idea that let's take it in reverse. So let's talk about antidepressants first, then we can talk about depression. So there's lots of reasons why people might feel better on antidepressants that has nothing to do with curing a chemical imbalance. Um, I would say number one, there's probably a few things. There's placebo effects. We know that accounts for a lot of the effect of antidepressants. Um, but I often think that the most important effect is this emotional numbing effect. So when you survey people on antidepressants, 3/4 of them say that they feel emotionally numbed. And what they're saying is the range of emotions from very positive to very negative has been constricted into the middle. Uh, and if you're very panicked or very depressed or very sad, having the volume turned down from a 10 to a 3 can be a great relief. People will say the drug worked. I don't feel as panicked or depressed. I think though the drugs are not so clever. They can't just target negative thoughts or negative feelings. They affect the entire, gamut of emotions. And so the number one reason people come to my clinic in London is because of emotional blunting. They say, I don't know who I am anymore. I'm not sure what I think about my spouse. I've had people say, I don't think I bonded with my children because I was so blunted during their childhood. So I think that, you know, I certainly believe people when they say they feel better being on the drugs. I just think the explanation that people have been given, for makes you think about it in a different way. Because of course, if a drug fixes a chemical imbalance, why would you ever stop it? I mean, if you've got diabetes and you need insulin, sort of fair enough. But if you're taking a drug that acts by numbing, but you've been given a story that the reason why it worked actually is something, much more compelling, we know that people that believe in a chemical imbalance are much more likely to not stop their drugs ever, because of course that's sort of sensible. And so in some studies in England, part of the intervention to help people stop the drugs is to explain to them that there is no such thing as a chemical
Yeah.
imbalance. So I think
It's
that's a sort of slight
it
rejigging of people's ideas.
it brings to mind, I used to work at a camp, and one time we had a camper fall off skiing in the lake, and lifeguards came out with the backboard, right? They strapped him in, they strapped him down because it's very important to keep it immobilized. But if in 2 years that kid is still on that backboard, there's something wrong. It's not the backboard that's helping it. It's the body needs time to heal. It needs to be immobilized. It needs to be blunted. But then you got to get off of it, otherwise you're going to have other problems. So they're just kind of like,
Like that's a great analogy. There's a professor of psychiatry who uses the exact same analogy. A
really?
cast, a cast is very you've gone straight to the top. A cast is very good for a broken arm, and if you keep your arm in it, you lose the ability to use that arm anymore. So I think that's
Yeah,
exactly right.
that's awesome. So I'm going to read one in full. This Daniel shared. Is there any chance you might be able to touch on benzo withdrawal and tapering? I was on 2 milligrams for 20 plus years and successfully reduced to zero 0.5 milligrams, but every attempt I've made has failed. My goal is to become a therapist who can support people going through this if I can ever get off this drug and heal.
I'll just say briefly because we
Yeah,
don't
you're
do
not giving
benzo.
it medical
But
advice. Yeah,
basically, the answer is it's very similar to antidepressants. All the same things apply. Hyperbolic tapering, physical dependence, withdrawal being mistaken as relapse, it not fixing a chemical imbalance, all the same things apply to coming off benzodiazepine.
gotcha. Let's see. Scrolling through so many good comments. Do we receive the slides? Yes, we will send the slides out, I assume. Um, on how much time on average is recommended for the hyperbolic approach?
So, great question. It's a little bit similar to what is the risk of withdrawal. So it depends. If someone has a very easy time coming off, it may just take a few months. If someone has a very hard time, it may take a few years. Um, in general, I think in outro in my clinic, the average time is about 18 months, give or take. Some people 6 to 12 months, some people take a bit longer. The main answer is it's the rate, should be as much as the patient can tolerate. So if it's very unpleasant, you need to slow things down. If it's fine, keep going. So it's very bespoke. And everyone wants to know what's the exact number I need. You sort of work it out as you go along, a little bit of trial and error within boundaries, and you work out what rate people can reduce at.
All right, so here's a physician prescriber. A common scenario for them is that they have a patient who's been on antidepressant for a very long time with no major side effects. They're not clear how much the meds are helping. Is it inevitable that there will be some intermittent mood difficulties in the weaning process, even with hyperbolic tapering? I think they mostly want to know if it's worth it to come off, just because they want to know if they can come off, or they should just keep them on just to not shake things up.
Yeah. So it's a very common reason to not come off the drugs, to not upset the apple cart. I will just say I've never ever met a patient who's been on the drugs for more than a few months that doesn't have a load of side effects. That's different for them knowing what they have. That's why I often give people a questionnaire to ask what they have. It's very rare they don't have some form of emotional numbing, sexual problems, cognitive impairment, weight gain, gut problems. Again, they don't often put it together with the drug. Some people only recognize when they're off the drug how much trouble they had on the drug. I say that time and time again. They realize they've been emotionally blunted because people call it actually spellbinding, medication spellbinding, that you're on the drug, that a little bit affects your ability to work out how you are. And so you don't quite realize that you have been a bit blunted, a bit sexually inhibited, and so forth until you're off the drug. Um, I mentioned as you get older, there are some potential physical health consequences. Um, so, you know, again, if you're on the drug for more than guidelines recommend, it means you're getting very little advantage from the drug, but you're exposed to all the same side effects. So for many people, the balance between harms and benefits will swing over time. Um, is it inevitable you'll have trouble coming off? No, it's inevitable if you come off quickly. So people sort of think, coming off, that means there must be terrible pain. I guess the whole point of outro and other ways of coming off slowly is to avoid that pain. So if you come off carefully in small amounts, you can have either mild or no symptoms. It depends. Some people are a bit luckier than others. So the main thing is, if you do come off, to do it carefully rather than rip people off. Yeah.
There's a question here, just kind of about scope, asking, as therapists, are we allowed to be guiding people's tapers? And I can say no, we do not do guiding of tapers. We do not make any medication decisions. However, if you're working with someone who's tapering and they come to you with something related to their taper, they can only benefit from you being educated and for knowing what's normal and what's not normal, and when you need to loop their prescriber in. So that's where our role is. They're going to need support, and so that's where our role comes in. What do you think about people who do a slow hyperbolic taper off long-term SSRIs and still hit akathisia or withdrawals after 0?
Yeah. So this gets into sort of a whole set of more complicated medical problems. Coming off slowly diminishes your risk. Sometimes when people describe things as being slow, it's not as slow as it could be. The slower you go, the less your risk of developing things like akathisia and these long-term withdrawal effects. It's not a complete guarantee. These drugs have a lot of harms built into them and coming off them. I think it's another reason to come off the drugs earlier rather than later, because we know the longer you're on the drugs, the harder and the more risky it is to come off. The bigger the issues with withdrawal. So, I think that the best practice using these drugs, to follow guidelines, is for people to be on for a few months. When they feel better, to come off them slowly, rather than be stuck on these drugs for years and decades, because the problems accumulate both in being on them and in coming off them.
Yeah. I know we're hitting time. I'm good to keep going and answer more questions if people want to. How about you, Mark?
I can do a couple more minutes,
A
but
few
I'm
more?
already a bit late for a meeting, so I'll just do
Okay,
it.
cool. Well, then let's just do this as the last one. Is there commonality why certain SSRIs are harder to stop than others?
There's a lot of research, a lot of interest, a lot of debate. Probably the ones that are harder to come off tend to affect norepinephrine as well as serotonin. So maybe they're acting on multiple receptors. They're having more of an effect. They tend to have shorter half-lives. That means they leave the body quicker than other drugs. And maybe it's the rapidity with which they leave the body that makes the body put them into a bit more shock. That's what people think are the main drivers of the difference.
Thank you so much for having this conversation with me and for everyone for showing up. There's you'll get an email if you want to sign up for the referral network. We'll also be looking for people in these states to work a little bit more closely with, so keep an eye out for that. Yeah, I hope to be able to do another event like this soon.
Thanks for listening, everybody, and thanks, Megan.